Welcome to the Hospital Medicine Unplugged podcast. Today we are examining recent excerpts from the Clinician's Manual for Polypharmacy and Deprescribing Management.
And the mission of this deep dive is to equip you, as a fellow clinician, with the precise evidence-based frameworks, the epidemiological data, and the specific clinical targets you need to safely de-escalate complex medication regimens.
Right. And we are focusing on both the inpatient and transitional care settings today, because we all recognize that the complexity of the patients you manage on your service every single day demands a rigorous approach.
It does. It is absolutely no longer sufficient to evaluate only what therapies we need to initiate. We have to critically evaluate what therapies we are obligated to discontinue.
To establish a foundation for this clinical analysis, we first need to define our parameters utilizing current consensus terminology from the literature.
Exactly. Starting with polypharmacy. It is most commonly defined in the major epidemiological studies as the concurrent use of 5 or more medications.
Though it is critically important to note that depending on the specific trial or the demographic they studied, that definition can actually range anywhere from 2 to 11 concurrent medications.
Right. But as practicing physicians, you constantly have to recognize the vital physiological distinction between appropriate and problematic polypharmacy.
That distinction is paramount when you are reviewing a transfer summary from the emergency department. Appropriate polypharmacy exists when all the medications on that list are prescribed for definitive, evidence-based indications.
And their dosing is precisely optimized for the patient's current hepatic and renal state.
Yes, like we see in our advanced heart failure, patients who appropriately require quadruple therapy.
Conversely, problematic polypharmacy occurs when medications are prescribed inappropriately, or when the cumulative physiological risks and adverse effect profiles just fundamentally outweigh the anticipated clinical benefits.
Which brings us to the formal definition of deprescribing. It is not merely the reactive cessation of a drug when an adverse event occurs.
No, not at all. It is a proactive, systematic, and patient-centered process. It's the act of identifying and discontinuing drugs when existing or potential harms outweigh the benefits.
And this process always has to be executed within the precise context of an individual patient's current goals of care. You have to consider their objectively measured level of functioning.
Their estimated life expectancy.
Exactly, and their specific values and preferences. It is an active medical intervention. It requires the exact same level of diagnostic acumen as prescribing a completely new agent.
When we look at the sheer scale of this issue in clinical practice, the volume is honestly staggering.
The prevalence data shows that polypharmacy affects approximately 30 to 40% of older adults dwelling in the community.
But the literature clearly demonstrates that the moment these patients cross the threshold of the hospital, the moment they're admitted to your service, that prevalence immediately jumps to 40 to 50% among hospitalized older adults.
Furthermore, if you are discharging a patient to a nursing home or admitting from one, the prevalence in that specific population reaches profound levels of 40 to 91%.
In the acute hospital setting specifically, depending on the parameters utilized, the prevalence is documented to range from 26.3% to 65.9%.
And what should really be concerning for your daily rounding practice is that approximately 20 to 50% of older adults are currently taking at least one potentially inappropriate medication.
What the literature commonly refers to as a PIM.
Right. We have to understand the epidemiological risk factors driving these statistics. The data clearly shows that each additional discrete chronic condition a patient develops increases their mathematical odds of polypharmacy by 88%.
We also see very clear demographic stratifications. Women are significantly more likely to experience polypharmacy than men,
which is partially driven by differences in health-seeking behaviors and longitudinal survival rates.
Additionally, lower socioeconomic status and lower educational attainment are consistently and independently associated with an increased burden of polypharmacy. This is seen across multiple multinational cohorts.
But we also have to turn the lens on our own environment. The inpatient setting itself inherently acts as a massive accelerant for polypharmacy.
The structural design of acute care essentially drives this acceleration. When you admit a complex older adult, their clinical trajectory invariably involves multiple highly specialized consultants.
And each of these physicians operates perfectly appropriately within the silo of their respective organ system expertise.
Exactly. A cardiologist will optimize a complex heart failure regimen to meet strict guidelines. Concurrently, a pulmonologist might escalate inhaled corticosteroid and bronchodilator therapy for a COPD exacerbation,
while a neurologist initiates new neuropathic agents for peripheral symptoms, and as the primary attending, you see the result.
Each consultant adds highly specialized medications aligned with their specific disease guidelines. Yet the cumulative iatrogenic burden, that aggregate physiological load placed on the patient's metabolic pathways, is rarely analyzed comprehensively.
Until the morning of discharge, if at all. Furthermore, our internal transitions of care frequently compound the issue.
Moving a patient from the emergency department to the general medical ward, or stepping them down from the ICU, frequently results in the inadvertent continuation of acute phase medications.
We consistently see agents like stress ulcer prophylaxis or sedatives continue long past their acute physiological indication.
Simply because they remain active on the electronic health record order set. I want you to consider your own census today. Evaluate the demographic profiles of the patients currently under your care.
How many of those individuals perfectly fit this exact epidemiological profile?
They present with complex multimorbidity, advancing age, and a medication list that is inexorably expanded with every successive healthcare encounter over the last decade.
When analyzing those patients, you must meticulously quantify the clinical burden that this medication volume imparts.
The literature demonstrates that adverse drug events occur in 20 to 30% of all hospitalized older adults.
And the presence of potentially inappropriate medications increases this risk of an adverse drug event by 1.5 to 2-fold.
But perhaps the most striking metric to keep in mind during medication reconciliation is that each additional medication a patient takes increases their discrete risk of experiencing an adverse drug reaction by approximately 10%.
The impact on definitive endpoints like mortality and hospital utilization is equally severe. Polypharmacy is independently associated with an increased all-cause mortality,
demonstrating a hazard ratio between 1.20 and 1.68 across rigorously controlled studies.
And a substantially increased risk of subsequent hospital readmission, showing an odds ratio of 1.41.
These are not merely administrative metrics. They represent profound physiological decompensation driven entirely by pharmacological overload. The morbidity associated with this overload extends significantly into mobility and trauma, which we manage daily on the wards.
Polypharmacy fundamentally increases a patient's overall fall risk. It demonstrates an odds ratio of 1.59.
Critically, the data reveals that each additional discrete medication increases a patient's absolute fall risk by 3 to 8%.
When we isolate the analysis specifically to potentially inappropriate medications, the data shows they are associated with a 1.4-fold increased risk of hip fracture,
an event that drastically alters the mortality trajectory of an older adult.
We must also evaluate the neurological impact. The cognitive and functional declines driven by problematic polypharmacy are starkly quantified in the research.
Polypharmacy is strongly associated with objective cognitive impairment, showing an odds ratio of 1.54.
And the development of clinical frailty, with an odds ratio of 1.73. This is consistently accompanied by significantly impaired performance in basic activities of daily living.
These adverse outcomes are frequently driven by a specific, highly insidious iatrogenic phenomenon known as a prescribing cascade.
The prescribing cascade is a critical concept to master. It affects approximately 1.2 to 3.7% of older adults.
It directly drives increased healthcare utilization, unnecessary diagnostic testing, and escalating costs.
A prescribing cascade occurs when an adverse drug effect is misinterpreted by a clinician as a completely new, spontaneous medical condition.
And this misinterpretation directly prompts the addition of a new secondary medication, specifically to treat the iatrogenic symptom caused by the first drug.
The physiological domino effect of these cascades is profound, and it's often deeply embedded in the patient's history.
Clinicians easily misidentify these cascades because the index of suspicion for iatrogenic etiology is inherently low during rapid diagnostic assessments in the ED or during busy ward rounds.
You see a symptom, you categorize it, and you treat it.
Because the physiological connection to an existing medication is missed, the cascade propagates, introducing new adverse effect profiles from the secondary and tertiary medications.
The source material explicitly details several highly common cascades that you must actively hunt for during every admission medication reconciliation.
The first involves the administration of NSAIDs.
We know these agents inhibit prostaglandin synthesis. In the renal system, this leads to a lack of vasodilatory prostaglandins,
causing afferent arterial or vasoconstriction, subsequent sodium and water retention, and ultimately iatrogenic hypertension.
Far too often, this drug-induced hypertension triggers the inappropriate initiation of a new antihypertensive agent rather than just the cessation of the offending anti-inflammatory.
Another extremely frequent and physiologically detrimental cascade involves the use of cholinesterase inhibitors prescribed for dementia.
These agents systematically increase acetylcholine levels to improve cognition.
However, this peripheral cholinergic agonism frequently precipitates sudden urinary incontinence by overriding detrusor muscle relaxation
This iatrogenic incontinence is then erroneously diagnosed as a new urological issue.
and treated with a profoundly counterproductive anticholinergic medication like oxybutynin.
The secondary drug crosses the blood-brain barrier and directly antagonizes the central cholinergic receptors we were originally attempting to stimulate.
We also frequently encounter cascades driven by psychiatric medications. Antipsychotics induce targeted dopamine blockade in the central nervous system.
However, off-target blockade in the nigrostriatal pathway frequently results in clinically significant Parkinsonism.
Instead of recognizing the temporal relationship between the antipsychotic initiation and the motor symptoms, clinicians often diagnose spontaneous Parkinson's disease.
And they prescribe anti-Parkinsonian drugs, which further complicates the central neurotransmitter balance and introduces new risks for delirium.
Further explicit examples detailed in the manual include the administration of metoclopramide for diabetic gastroparesis or refractory nausea.
Metoclopramide centrally antagonizes dopamine D2 receptors. In older adults, this rapidly precipitates extrapyramidal symptoms, including akathisia or dystonia.
This profound discomfort frequently leads a responding clinician to inappropriately initiate a central anticholinergic agent, such as benztropine,
Completely missing the underlying pharmacological trigger.
We must also be vigilant regarding antihypertensive agents themselves initiating cascades. Thiazide diuretics, which are widely utilized as first-line therapy for essential hypertension, frequently decrease the renal tubular excretion of uric acid.
This physiological shift predictably precipitates hyperuricemia and acute gout flares.
This iatrogenic gout then routinely results in the long-term initiation of allopurinol, exposing the patient to the severe hypersensitivity risks of that specific agent.
Rather than prompting a transition to an alternative antihypertensive class.
Finally, you must evaluate the use of dihydropyridine calcium channel blockers, such as amlodipine.
These agents cause preferential precapillary arteriolar vasodilation by blocking L-type calcium channels.
However, they do not induce commensurate postcapillary venodilation.
This resulting hydrostatic pressure gradient forces fluid out of the vasculature and into the interstitium,
manifesting clinically as dependent peripheral edema.
Rather than recognizing this highly specific mechanism and discontinuing or dose-reducing the calcium channel blocker, a loop or thiazide diuretic is frequently and entirely inappropriately added to manage the edema.
This loop diuretic then depletes intravascular volume, risking acute kidney injury without resolving the fundamentally hydrostatic cause of the swelling.
To systematically identify these specific cascades and isolate potentially inappropriate medications amidst a list of 15 drugs, you must integrate validated diagnostic tools into your clinical workflow.
Relying solely on intuition is insufficient.
The 2023 American Geriatric Society Beers criteria remains the most current and widely utilized structural framework in North America.
It rigorously stratifies medications into 5 distinct clinical categories to guide your evaluation.
Those 5 categories are precisely defined. First, medications to avoid in most older adults regardless of their underlying disease state due to an inherently unfavorable risk profile.
Second, medications to avoid in older adults with certain established diseases or syndromes that the specific drugs can exacerbate.
Third, medications to use with caution requiring enhanced monitoring.
Fourth, potentially clinically important drug interactions that compound physiological risk.
And fifth, medications that must be avoided or have their dosage significantly reduced based strictly on objective metrics of renal function.
The 2023 updates to the Beers criteria provide critical new guidance that directly impacts our daily prescribing habits.
Most notably, the update definitively classifies aspirin utilized for primary cardiovascular prevention in adults 70 years of age and older as a potentially inappropriate medication.
The data clearly demonstrated that the increased risk of major hemorrhagic events definitively outweighs the theoretical prevention of initial atherothrombotic events in this specific age cohort.
The 2023 update also strongly reinforces the strict avoidance of antipsychotics for the behavioral and psychological symptoms of dementia, barring severe cases of imminent physical threat.
It substantially expands the cautionary guidance on benzodiazepines and highly related Z-drugs, like zolpidem,
emphasizing their minimal long-term efficacy against their profound neurological risks.
Furthermore, it updates explicit recommendations regarding the prolonged use of proton pump inhibitors,
establishing strict temporal parameters for their discontinuation in the absence of a hypersecretory condition or high-risk gastrointestinal bleeding history.
While the Beers criteria is extensively utilized and integrated into many of our workflows here in North America, you must also be highly familiar with the Stop PP Start criteria.
The comprehensive third version of this tool was published in 2023. Stop PP stands for Screening Tool of Older Persons Prescriptions.
This arm of the framework contains 94 distinct criteria for identifying potentially inappropriate medications.
Conversely, START stands for Screening Tool to Alert to Right Treatment.
This is a critical addition, encompassing 34 explicit criteria aimed at identifying potential prescribing omissions.
This dual approach is vital because problematic polypharmacy frequently coexists with the underprescribing of definitively beneficial guideline-directed therapies.
The literature actually suggests that the Stop EP Start criteria may be more sensitive than the Beers criteria for detecting potentially inappropriate medications in European populations,
reflecting regional differences in prescribing patterns and available formularies.
The inclusion of both overprescribing and underprescribing metrics offers a highly comprehensive clinical assessment.
It prevents us from fixating solely on subtraction while missing glaring omissions, such as a lack of anticoagulation in high-risk atrial fibrillation.
When integrating these specific tools into your daily rounding workflow, the choice between utilizing Beers or Stop Start often depends on institutional preference
and the level of embedded electronic health record integration available at your facility.
However, both tools demand rigorous physiological reasoning from the physician rather than mere passive checklist application.
Beyond the foundational Beers and Stop Start frameworks, the literature validates several additional quantitative metrics you can utilize for complex cases.
The Medication Appropriateness Index, or MAI, is a rigorous 10-item tool.
It forces the clinician to systematically assess indication, overall effectiveness, precise dosage, clarity of directions, practical application for the patient,
as well as drug interactions, drug-disease interactions, therapeutic duplication, intended duration, and finally, financial cost.
There is also the F4TA classification, which stands for Fit for the Aged.
This system labels drugs systematically. A for absolutely indispensable, B for demonstrably beneficial, C for questionable efficacy requiring careful review,
and D for drugs to actively avoid.
Another crucial, highly specific metric is the anticholinergic cognitive burden scale.
This tool mathematically quantifies the cumulative anticholinergic burden across all prescribed agents.
A score of greater than or equal to 3 on this specific scale is strongly and independently associated with an increased risk of severe cognitive impairment and overall mortality.
Finally, we have the Drug Burden Index, which quantifies the cumulative physiological exposure to both anticholinergic and sedative medications simultaneously,
providing a composite risk score for functional impairment.
Understanding the rigorous evidence base underlying all of these tools is essential for justifying the time required for their application on a busy medical ward.
We do not engage in deprescribing merely as an academic exercise. We do it because the data supports it.
Systematic reviews and comprehensive meta-analyses consistently demonstrate that structured deprescribing interventions can significantly reduce the total number of medications a patient takes,
without causing significant physiological harm or exacerbating underlying disease states.
A pivotal 2018 Cochrane review synthesized this data, finding that structured deprescribing interventions successfully reduced the number of medications by an average of 0.9 medications per patient across diverse cohorts.
That Cochrane review definitively demonstrated that clinicians can safely reduce the burden of potentially inappropriate medications without increasing overall mortality or precipitating severe, unmanageable adverse drug withdrawal events.
However, as evidence-based practitioners, you must interpret this specific data with strict clinical nuance.
The evidence for broader, transformative clinical benefits beyond the simple numerical metric of medication reduction remains somewhat inconsistent in the current literature.
While the mathematical pharmacological risk and cumulative toxicity are undeniably lowered, the demonstrably proven effects on discrete long-term clinical outcomes show significant variability.
Outcomes like the absolute reduction in fall rates, the stabilization of long-term cognitive trajectories, improvements in quantified overall quality of life, and the definitive prevention of future hospital admissions.
It shows variability across different patient cohorts and varying study designs. We reduce the risk, but reversing established functional decline is a far more complex physiological challenge.
To operationalize this nuanced evidence base at the bedside, you should utilize structured deprescribing frameworks to guide your clinical decision-making.
The manual explicitly highlights the 5-step deprescribing protocol.
Step 1 requires you to comprehensively ascertain all drugs the patient is currently taking, including over-the-counter agents and supplements, and rigorously verify the precise current physiological indication for each.
Step 2 involves analytically considering the overall risk of drug-induced harm in the specific context of that individual patient's multimorbidity.
Step 3 requires assessing each specific drug for its definitive eligibility for discontinuation. Can it be stopped immediately, or does it require a taper?
Step 4 involves logically prioritizing the drugs for discontinuation. You must specifically target those agents presenting with the highest potential for immediate harm and the lowest potential for ongoing clinical benefit.
Finally, Step 5 requires implementing a strictly structured discontinuation regimen and rigorously monitoring the patient for targeted clinical improvement or the emergence of adverse drug withdrawal events.
Additionally, the literature supports the CEASE framework, which provides a highly effective, memorable cognitive scaffold for your evaluation.
CEASE stands for Coordinated, Evidence-Based, Appropriate, Safe, and Effective.
This specific framework provides a highly structured approach to the medication review process while heavily emphasizing the necessity of patient-centered shared decision-making.
When applying these specific frameworks, you must consciously adapt them to the realities of your specific clinical setting.
Extrapolating these structured protocols during a short, highly acute hospital admission requires a vastly different operational approach than utilizing them as a medical director in a long-term care facility.
In the acute hospital setting, your primary clinical objective is undeniably acute stabilization of the presenting illness.
However, the admission also represents a critical, often rare intervention point to identify glaring medication appropriateness issues.
Initiate high-yield, rapid tapers and clearly communicate the intended longitudinal deprescribing trajectory to the receiving transitional care or outpatient primary care physician.
In stark contrast, the long-term care setting allows for the implementation of prolonged, meticulously calibrated multi-month tapering schedules,
combined with high-frequency longitudinal monitoring by nursing staff.
Regardless of the setting, when you commit to a deprescribing plan, deeply understanding the specific withdrawal risks and expertly executing high-risk tapering protocols is paramount to patient safety.
Abrupt discontinuation of numerous common medication classes presents severe, highly predictable physiological risks.
For benzodiazepines, abrupt cessation risks severe withdrawal seizures, profound rebound anxiety, and intractable insomnia.
Therefore, you must systematically taper these specific agents over a period of weeks to months, depending on the half-life of the specific drug and the chronicity of use.
Beta blockers require careful tapering over 1 to 2 weeks.
Abrupt cessation removes the suppression of sympathetic tone, risking severe rebound tachycardia, malignant hypertension, and the potential precipitation of acute angina or myocardial ischemia.
Particularly in patients with underlying coronary artery disease, corticosteroids present a profound risk of secondary adrenal insufficiency.
If they have been used consecutively for greater than 3 weeks, the exogenous suppression of the hypothalamic pituitary adrenal axis necessitates a highly gradual, physiologically monitored taper.
To allow for the recovery of endogenous cortisol production.
Antidepressants, particularly the selective serotonin reuptake inhibitors and serotonin norepinephrine reuptake inhibitors, carry a highly significant risk of discontinuation syndrome.
Characterized by severe sensory disturbances and mood lability, they must be tapered carefully over 2 to 4 weeks.
The pharmacodynamics fundamentally driving these specific withdrawal syndromes are deeply rooted in target receptor adaptations.
Chronic administration of any exogenous pharmacological agent forces the central nervous system or the endocrine axis to physiologically adapt.
The body will fundamentally downregulate endogenous hormone production or alter cellular receptor density to maintain systemic homeostasis in the presence of the drug.
For example, chronic opioid administration causes profound alterations in mu-opioid receptor sensitivity and density within the central nervous system.
To mitigate the severe autonomic hyperactivity of withdrawal syndromes, opioids absolutely require a gradual, sustained taper.
The literature typically recommends utilizing a conservative 10% dose reduction every 1 to 4 weeks,
allowing receptor density to gradually normalize. Antiepileptics require exceptionally slow tapers, often spanning several months.
to prevent acutely lowering the seizure threshold and precipitating dangerous seizure recurrence.
Proton pump inhibitors present a different physiological challenge. Chronic suppression of gastric acid causes secondary hypergastrinemia.
Which directly drives parietal cell hyperplasia in the gastric mucosa due to the prolonged loss of negative feedback.
Abrupt cessation of the PPI leads to massive, unchecked rebound acid hypersecretion from these hyperplastic cells.
Managing this specific risk often requires utilizing a histamine H2 receptor antagonist bridge.
Or instituting a very gradual dosage taper to prevent severe symptom recurrence.
We must also be highly cautious with centrally acting alpha-2 agonists like clonidine.
Chronic administration causes a profound downregulation of presynaptic alpha-2 receptors in the vasomotor center.
This means abrupt cessation results in massive, completely uninhibited sympathetic outflow,
Clinically manifesting as severe, potentially life-threatening rebound hypertension.
Finally, central muscle relaxants like baclofen require meticulous management.
Baclofen withdrawal can precipitate severe neurological complications, including refractory seizures and vivid hallucinations, requiring incredibly precise incremental dose reductions.
Communicating these highly precise timelines and the exact expected physiological sensations to your patients prior to initiating the taper is absolutely crucial to preventing immediate relapse.
Patients who experience sudden, completely unmanaged, and unexpected withdrawal symptoms will rapidly lose all trust in the deprescribing process.
And immediately resume the offending agent. Focusing our limited time on high-yield deprescribing targets provides the most immediate, measurable benefit for the complex patients on our service.
Proton pump inhibitors are definitively among the most frequently overutilized and unnecessarily prolonged medications in modern practice.
The literature clearly indicates that up to 70% of prolonged PPI use in hospitalized patients completely lacks an appropriate evidence-based indication.
The systemic risks of this inappropriate continuation are severe and well documented.
Chronic PPI use is independently associated with an increased risk of Clostridioides difficile infection, demonstrating an odds ratio of 1.7 to 2.9.
Alongside statistically significant increased risks for community-acquired pneumonia, the progression of chronic kidney disease, and osteoporotic bone fractures.
Fortunately, deprescribing PPIs is both safe and highly effective. Clinical studies demonstrate that 14 to 64% of patients can successfully discontinue these agents entirely without any long-term symptom recurrence.
However, as we just discussed regarding parietal cell hyperplasia, rebound acid hypersecretion occurs in 40 to 50% of these patients.
It is absolutely vital to counsel your patients proactively that this rebound phenomenon is a purely transient physiological adjustment.
And it typically resolves entirely within 2 to 4 weeks.
Consider a highly frequent clinical scenario you face on the wards. You are evaluating an older adult admitted to your internal medicine service for community-acquired pneumonia.
Upon rigorous chart review and medication reconciliation, you note they were started on intravenous pantoprazole during a prior intensive care unit admission strictly for acute stress ulcer prophylaxis several months ago.
They were subsequently discharged without the medication ever being formally discontinued by the transitional care team.
To safely taper this specific patient, you must initiate a highly structured dose reduction protocol. You might begin by transitioning them from a daily to an every other day dosing regimen for a period of 1 week.
Crucially, you must explicitly educate the patient that they may experience transient mild dyspepsia directly due to gastrin-mediated parietal cell rebound.
You must assure them with clinical certainty that this specific discomfort does not mean they have a newly developed permanent gastrointestinal disease requiring the drug forever,
but rather a temporary expected physiological adjustment.
Supplying a short, as-needed course of a simple antacid, like calcium carbonate, specifically for breakthrough symptoms during this transition, empowers the patient.
It provides them with a safe mechanism for symptom control and vastly increases the statistical likelihood of long-term discontinuation success.
Benzodiazepines represent another critical high-yield target for intervention. They are independently and strongly associated with a vastly increased risk of mechanical falls, subsequent osteoporotic fractures, objective cognitive impairment, the precipitation of acute hospital delirium, and fatal motor vehicle accidents.
The published data shows deprescribing success rates for benzodiazepines ranging widely from 27 to 80%, heavily depending on the structural intensity of the clinical intervention and the level of patient support.
Gradual physiological tapering over 10 to 12 weeks is strictly recommended by consensus guidelines, typically utilizing conservative dose reductions of approximately 25% every 1 to 2 weeks.
The literature also distinctly notes that the concurrent application of targeted cognitive behavioral therapy for insomnia significantly improves the long-term success rates for complete benzodiazepine cessation.
Antipsychotics also require aggressive, continuous monitoring by the hospitalist, as the data shows they're used inappropriately in 20 to 50% of hospitalized older adults.
This inappropriate utilization most frequently occurs for the management of the behavioral and psychological symptoms of dementia, an indication completely lacking robust evidence.
In this specific, highly vulnerable population, antipsychotics carry a profound 1.6 to 1.7-fold increased absolute risk of mortality.
Deprescribing is entirely feasible and safe in 50 to 75% of nursing home residents without any subsequent worsening of their behavioral symptoms, provided you utilize a gradual dose reduction strategy spanning 3 to 6 months.
The cumulative anticholinergic burden is another absolutely vital metric for targeted bedside intervention.
As previously established when discussing our diagnostic tools, an anticholinergic cognitive burden score of greater than or equal to 3 is independently associated with a hazard ratio for overall mortality of 1.68.
Alongside precipitous, measurable cognitive decline and severe functional impairment.
You must aggressively target and discontinue the most common pharmacological culprits. First-generation antihistamines like diphenhydramine, tricyclic antidepressants, urological bladder antimuscarinics, and specific, highly anticholinergic antipsychotics.
The systematic, targeted reduction of this specific anticholinergic burden is widely considered one of the very few pharmacological interventions that may actually directly improve baseline cognitive function in older adults,
rather than merely slowing its decline.
Furthermore, regarding inpatient glycemic control, the routine use of sliding scale regular insulin in the inpatient setting is consistently associated in the literature with significantly increased rates of dangerous hypoglycemia,
without demonstrating any measurable improvement in overall systemic glycemic control.
Transitioning hospitalized patients who genuinely require insulin therapy to physiologically sound, guideline-directed basal bolus regimens is strongly preferred.
Identifying and eliminating archaic sliding scale orders represents a crucial, highly impactful component of medication optimization during any acute admission.
Successfully executing these specific deprescribing targets, however, requires systematically overcoming significant embedded system barriers and profound patient-level psychological barriers.
The primary patient data regarding their willingness to engage is actually highly encouraging for clinicians.
Rigorous surveys demonstrate that 92% of older adults explicitly indicate they are willing to completely stop one or more of their current medications if their primary physician explicitly states it is clinically possible and physiologically appropriate.
However, the data also shows that patients fundamentally overestimate the long-term benefits of their maintenance medications and significantly underestimate the accumulated physiological harms and toxicity risks.
The most common patient concerns documented in the deprescribing literature include a profound fear of symptom recurrence, reported by 73% of patients surveyed.
There is also a deeply held psychological belief that the medications are strictly necessary for their ongoing survival, reported by 62%.
Additionally, there is a profound, often unspoken concern about disappointing the original prescribing physician, reported by 38% of patients.
Notably, if a patient has had a positive, well-managed deprescribing experience in the past, their willingness to engage in future medication reduction initiatives increases substantially.
Addressing the patient's explicit fear of disappointing their primary prescriber is a highly delicate communication task during bedside rounding.
You must carefully frame the deprescribing intervention not as a sudden correction of a prior specialist medical error,
but rather as a necessary, completely expected evolution of their medical care, reflecting the patient's changing internal physiology. You must validate the previous decision while pivoting to the current reality.
The precise phrasing at the bedside matters immensely. You might explain to the patient that the specific medication was perfectly appropriate and guideline-directed when it was initially prescribed 5 years ago.
However, you must then clearly explain that their current renal clearance rates, their hepatic metabolic capacity, and their overall clinical goals of care have fundamentally shifted as they have aged.
Therefore, the medication regimen must be actively adjusted to match their current physiological state.
To overcome the broader systemic barriers to deprescribing, the published evidence strongly supports the widespread integration of pharmacist-led interventions.
Dedicated pharmacist-led medication reviews successfully and consistently reduce the number of potentially inappropriate medications by 21 to 35%.
Furthermore, these specific interventions are independently associated with a measurable reduction in hospital readmissions, demonstrating a relative risk of 0.78.
They are also highly cost-effective for healthcare systems, generating estimated administrative savings of $3 to $7 for every single dollar invested in pharmacist time.
The formal implementation of comprehensive medication management programs consistently improves medication appropriateness scores and definitive clinical outcomes.
These programs utilize a highly structured approach involving rigorous therapy review, the creation of highly accurate personal medication records, detailed patient action plans, and rigorous longitudinal follow-up.
We must also evaluate the role of electronic health record, or EHR, interventions in supporting our workflow.
EHR systems can utilize complex dashboards, targeted clinical decision support alerts, and automated deprescribing prompts presented to the physician at the exact moment of hospital discharge.
Specific, highly targeted interventions include POD and review alerts triggered specifically for long-term medications that exceed guideline durations,
such as a PPI prescribed continuously for greater than 8 weeks without a documented hypersecretory diagnosis.
However, the aggregated evidence for these EHR interventions shows decidedly mixed clinical results.
While some highly targeted single-center studies demonstrate a 10 to 20% reduction in potentially inappropriate medications, widespread systemic implementation frequently results in severe alert fatigue for the busy hospitalist.
When you are managing a complex admission, constant intrusive alerts lead directly to dismissive override behaviors and profoundly low overall clinician acceptance rates.
The evaluation of EHR utility must carefully and constantly balance the theoretical need for helpful prompts against the very real cognitive burden placed on the frontline clinician.
Navigating these highly complex systemic and physiological variables becomes even more nuanced when we are explicitly treating defined special populations.
For patients with a definitively limited life expectancy, your primary clinical objective must shift entirely and unapologetically toward immediate symptom management and the aggressive, systematic discontinuation of all purely long-term preventive medications.
The physiological time to benefit for these drugs vastly exceeds the patient's prognosis.
In patients with advanced dementia, you must prioritize the rapid, carefully monitored discontinuation of all centrally acting anticholinergics and antipsychotics, as well as any peripheral medications offering minimal immediate symptomatic benefit.
When managing patients with severe multimorbidity, you face the constant daily clinical challenge of balancing competing, rigid, disease-specific guidelines against foundational geriatric principles of harm reduction.
Disease-specific guidelines perpetually and systematically recommend the addition of condition-specific pharmacological agents to meet rigid population targets.
Conversely, geriatric principles heavily emphasize the reduction of iatrogenic harm and the preservation of immediate functional independence.
How do you logically negotiate these competing forces in a highly complex, frail patient?
You must rigorously evaluate the specific time to benefit of each individual agent.
That time to benefit framework is essential. If a specific guideline-directed therapy, such as an aggressive lipid-lowering agent, requires a full 10 years to confer a statistically significant mortality benefit, but the patient's severe clinical frailty suggests an objective life expectancy of perhaps 3 years,
the medication is physiologically inappropriate to initiate or continue, entirely regardless of what the isolated cardiology disease guideline dictates.
This precise clinical reasoning is absolutely essential when managing specific high-risk medication classes like diabetes medications.
For frail older adults, major clinical guidelines formally recommend significantly relaxed glycemic targets, specifically targeting an HbA1c between 7.5 and 8.5%.
You should strongly and actively consider deprescribing or substantially dose-reducing hypoglycemic agents if the frail patient's HbA1c falls below 7%.
The immediate catastrophic risk of severe, life-threatening hypoglycemia associated with the use of sulfonylureas and complex insulin therapy far outweighs the purely theoretical long-term microvascular benefits in these specific frail populations.
Statins present a very similar risk-benefit paradigm that requires careful analysis.
Their routine use for primary cardiovascular prevention in adults over 75 years of age without any established cardiovascular disease is highly questionable based on current trial data.
The statistical number needed to treat to prevent a single non-fatal cardiovascular event increases substantially with advancing age,
rendering the immediate risks of statin-induced myopathy or cognitive changes far more relevant. making deprescribing of these agents entirely appropriate in patients with limited life expectancy or those exhibiting significant clinical frailty.
Antihypertensives in frail older adults demand an equal level of rigorous clinical scrutiny.
Intensive blood pressure control aims to definitively prevent long-term cardiovascular sequelae, such as stroke or myocardial infarction.
But in this highly specific demographic, aggressive treatment dramatically increases the immediate daily risk of orthostatic hypotension, subsequent mechanical falls, and traumatic syncope.
A relaxed target blood pressure of 130 to 140 over 70 to 80 millimeters of mercury is physiologically appropriate and significantly safer for frail older adults.
The published literature confirms that systematically deprescribing at least one antihypertensive agent is entirely feasible in the vast majority of these frail patients without precipitating any clinically significant or physiologically dangerous rebound in their systemic blood pressure parameters.
It requires monitoring, but the risk of hyperperfusion-related injury is substantially mitigated.
Looking forward at the rapidly evolving landscape of our profession, the future directions in formal deprescribing are heavily focused on advanced technological integration.
Artificial intelligence and complex machine learning algorithms are beginning to utilize advanced natural language processing to extract highly nuanced, previously hidden medication information directly from unstructured clinical notes and historical specialist summaries.
These machine learning algorithms are actively being developed to generate highly accurate predictive models that can instantaneously identify the exact specific patients on a hospital census who are at the absolute highest statistical risk from polypharmacy-induced harm.
Precision deprescribing is another rapidly emerging frontier. This involves utilizing advanced pharmacogenomic testing to definitively guide both initial medication selection and precise, individualized dosing parameters.
This precision approach will be combined with biomarker-guided deprescribing protocols that rely on real-time serum drug levels and highly precise dynamic renal function metrics to create individualized dynamic risk prediction models for every patient on your ward.
Furthermore, dedicated deprescribing networks and evolving value-based care initiatives are fundamentally restructuring our systemic financial incentives.
Organizations like the Canadian Deprescribing Network are actively driving the rigorous development of validated shared decision-making aids and systematically integrating medication optimization as a highly visible, core quality indicator for hospital systems.
Accountable care organizations are increasingly beginning to offer distinct, measurable financial incentives for appropriate, documented deprescribing practices that reduce overall systemic harm and subsequent healthcare utilization.
Amidst all these technological advances, physical transitions of care remain the absolute most critical operational point for these initiatives.
The acute hospital discharge is your primary and often only opportunity for definitive medication optimization.
This requires mandatory, highly accurate post-discharge medication reconciliation within 48 to 72 hours.
It also necessitates the execution of comprehensive warm handoffs to the receiving primary care physician that contain explicit, evidence-supported, and structured deprescribing recommendations.
We must fundamentally evaluate how our workflows will adapt. Imagine how hospital medicine workflows will fundamentally change when a fully integrated AI system automatically flags a patient's exact physiological risk profile for a specific prescribing cascade the exact moment they present to the emergency department triage desk.
Analyzing their complex genetic metabolizer status and their dynamic renal clearance simultaneously.
This brings us to the fundamental, necessary evolution of our systemic prescribing culture. The sheer overwhelming volume of data we must synthesize daily for a single older adult presenting with complex multimorbidity requires a clinical infrastructure that supports the subtraction of therapies just as robustly and with as much diagnostic rigor as it supports the addition of new agents.
As practicing clinicians, your daily rounding workflow must actively incorporate this systematic review to actively mitigate the immense iatrogenic burden we inadvertently place on these highly vulnerable populations.
This has to be the new standard of care.
If artificial intelligence and advanced pharmacogenomics eventually allow us to predict with absolute physiological certainty which specific medications will cause definitive harm in an individual patient, how will that ultimately redefine broad population-based guidelines like the Beers criteria? Will the very concept of a potentially inappropriate medication become entirely obsolete, completely replaced by the classification of definitively inappropriate for that specific genetically profiled patient? Thank you for joining your peers on this deep dive into the literature.